Welcome. Today we shall be looking at Kawasaki disease. Kawasaki disease, also known as mucocutaneous lymph node syndrome, is an acute systemic inflammatory illness. Although the exact cause is unknown, it is thought to be triggered by a bacterial or a viral infection. Kawasaki disease is a self-limiting vasculitis of medium-sized vessels, primarily affecting the coronary arteries. This disease mainly affects children who are under 5 years of age, particularly those from the Asian descent. It is the leading cause of acquired heart diseases in children, and if left untreated, it may lead to development of serious complications such as coronary aneurysms, myocardial infarction, cardiac tamponade, arrhythmias, or even death. We have 3 stages of Kawasaki disease: an acute stage, subacute stage, and a convalescent stage. During the acute stage, Kawasaki disease presents with a high fever, conjunctival hyperemia and mucositis that is commonly known as strawberry tongue. There may be also swelling and redness of the hands and feet, and a generalized rash. Enlargement of the cervical lymph nodes is also a common feature, and additional symptoms include increased irritability, arthritis, and cardiovascular signs, for example tachycardias and a gallop rhythm. The subacute stage begins when the fever resolves and continues until outward symptoms subside. During this time, the patients may experience the cracked lips, peeling of the skin on the fingers and toes, joint pains, cardiac symptoms, and increased platelet counts, leading to hypercoagulability. In the convalescent stage, a child appears clinically well, but the laboratory signs of inflammation may persist. The diagnosis of Kawasaki disease requires a fever that's lasting 5 or more consecutive days, along with at least 4 of the following: conjunctivitis, rash, adenopathy, strawberry tongue, and the swelling of the hands and feet. Incomplete Kawasaki disease can as well be diagnosed based on echocardiographic evidence of coronary artery involvement. The crash and burn mnemonic helps us to recall the key diagnostic criteria for Kawasaki disease. C stands for conjunctivitis, R for rash, A for adenopathy, S for strawberry tongue, H for hand and foot swelling, and burn for fever that is lasting at least 5 days. Kawasaki-related conjunctivitis is typically bilateral, painless, and non-exudative. The eyes of these patients appear red and swollen, often accompanied by photophobia and uveitis in over 60% of the cases. A non-itchy generalized macular erythematous rash is often seen on the trunk, extremities, the groin region, and the perineum together with the buttocks. This skin may begin to peel 2 to 3 weeks after the fever begins. Bew lines, which are transverse lines on the nails, may develop on the majority of the cases. That is up to 75%. Cervical lymphadenopathy is usually unilateral, with at least one lymph node larger than 1.5 centimeters. A strawberry tongue refers to a red, swollen, bumpy tongue that may have a white coating, and the lips are often inflamed, cracked, and fissured. There is as well a redness and swelling of the palms and the soles, which can progress to peeling of the skin, and remember, these areas may be tender and painful to touch or even to walk on. In the last part of the mnemonic, known as burn, a fever that is lasting more than 5 days is the most consistent symptom of Kawasaki disease. It is often poorly responsive to antipyretic medications. The key interventions for patients with Kawasaki disease include frequent temperature monitoring, assessment of cardiovascular signs, and a close examination of the extremities and mucous membranes. It is usually essential to monitor fluid intake and output, offer some soft drinks and liquids, and you weigh these children daily, encouraging passive range of motion exercises to maintain a joint mobility. You need to administer acetyl salicylic acid, specifically aspirin, at a moderate to high doses for its antipyretic and antiplateletic effects. If coronary aneurysms are present, an additional anticoagulation may be required. A high dose of intravenous immunoglobulin is given to shorten the fever and reduce the coronary artery complications. Since intravenous immunoglobulin is a blood product, proper precautions must be followed during administration. Educating the parents of children with Kawasaki disease is essential, and symptoms like irritability may persist for up to 2 months, while peeling of the hands and the feet and joint pain can last for several weeks. Parents to these children should be able to monitor for morning stiffness or pain after naps in cold weather, and temperature should be recorded daily until the child has been fever-free for several days. If the child develops a fever above 101 degrees Fahrenheit, you need to notify the healthcare provider immediately. As salicylic acid is often prescribed, parents should watch for signs of aspirin toxicity, for example, tinnitus, headache, vertigo, and easy bruising. Aspirin should not be given if the child has been exposed to chickenpox or flu. Some signs of bleeding may include nosebleeds, coughing, and vomiting of blood, blood in urine, or even blood in stool. There could be as well unexplained bruising in these patients. Some cardiac complications, for example chest pain, cold extremities, or unexplained irritability, should be taken seriously in these children, and children who are put on aspirin or anticoagulant therapy should avoid contact sports. Finally, live vaccines, for example measles, mumps, and rubella vaccine known as MMR or a varicella vaccine, should be postponed for 11 months after intravenous immunoglobulin therapy if appropriate.